Today I'm in conversation with Inke Schreiber. Inke is a clinical psychologist. Hi, Inke.
Hi.
Hi. Welcome so much to the series and bringing your voice to this. It's really, really fantastic. I wondered if you could speak to us a little bit about why speaking in this series is important to you.
Yeah. So I suppose I've been thinking about the idea of lived experience during my doctorate training, which I did my thesis on. I looked at how mental health professionals use their lived experience in their work. Although I have been interested in how people use their lived experience of distress, I think probably ever since starting work in the NHS, I suppose noticing that there were divisions between staff and patients. One of my very first jobs was in a child and adolescent mental health inpatient wards. I was, like 19 or 20 at the time when I took a job as a support worker, so quite fresh out of like my undergraduate. And I suppose there was a kind of acknowledgement from my part that I was drawn to that type of work, especially with young people, at least in part because of my own experiences that I've had growing up. And I suppose feeling like I could bring something that felt helpful and valuable in some way. And so there was me walking into the inpatient unit, and I was just really shocked and struck by how little there was an interest in the staff side of kind of coming into the work. I think inpatient wards on the whole are quite controlled and regimented environments anyway, but there was just a very clear division about we are staff and these are the patients, and our task is to look after them, make sure that they don't essentially kill themselves or cause any harm to anyone else. But that's about it. And I really struggled with that. I really, really struggled with that. And I found myself having conversations with the young people there where I was sort of a bit like, I think I'm helping you. I think this is a good idea. But being really incredibly anxious about what would happen if a young person told, not another young person, but a staff member, oh, I've had a conversation with Inke and she told me X, Y, and Z. And feeling like I would be in some way penalised or told that I'd done something wrong.
You mean speaking about your lived experience to them?
Yes.
Yeah.
Having had a conversation about anything personal that had happened to me, it just seemed like a massive taboo. Even though, I have to say in terms of what the reactions from the young people, I did feel like, I think this is helpful. I think this is doing, especially when it comes down to the kind of loneliness and isolation that young people can experience when they are distressed. I did notice that there was something about joining somebody in their distress and sort of saying, well, I don't think I've experienced the same thing, but, sometimes I felt like this, that, and the other. Is that what you have felt? I noticed that there was a real, I noticed that had a real impact on them, and I suppose it sort of started my questioning about who are these boundaries for? Who are they protecting us? Are they to protect us, or are they to protect the young person? And so it's something that I've kind of carried on thinking about as in the process of my career, and then ultimately doing this research project. And I suppose doing this interview feels a bit like I can engage in some healthy activism, I suppose share my own story, which is the bit that in some ways has been missing maybe. I feel like I've done a lot other things around it, but it's been in a sort of, I suppose, in a distance and almost outside a way, especially in doing the research. But I think when I did my MRP, my thesis, it just struck me how much we still battle with stigma and shame in all the mental health professions around experiencing distress. And I feel like I would like to contribute in some way to try and, I suppose challenge some of that, this idea that mental health professionals are well and sane and healthy and they don't have problems and they don't need help. I think it's a really unhelpful idea. And so I think challenging that is what I'm hoping to do here today.
That's fantastic. that's it. And you're not alone. You're with the other people who've spoken in this series too. And I think it does need challenging, absolutely, because it puts people into very precarious positions. I would say dangerous positions, actually, when you're a provider, if you're unable to say that you need help or support. And also if you also feel that you're unable to bring the value of your own lived experience to thinking about how a service is run, or something about how the provision is made. Could be some really good, really good stuff there, in the same way that we would value it, or we would hope it's valued in those who use our services. But I guess we've still got a long way to go from the things that I hear about co-production.
Yes, we do. We have a long way to go.
Maybe it's the extent to which we value our own lived experience is really the extent to which we actually really value the lived experience of those coming to us. So we have work to do with these mirrors,
Definitely, yeah. Definitely. And I suppose, I suppose for me that there is the idea of the mirror is an interesting one, because I think there is a reluctance, I think, from ourselves to sometimes look at the stuff that we bring. I often feel like services, like I kind of alluded to before, I often feel like services are set up in a way to protect us rather than really provide something helpful to the people that we're seeing. It's like we go into the help profession, but not really to help, but to feel good about ourselves in some way, to kind of almost elevate our own status, but to keep, and there is something important about keeping, service users in the place where they're at, so that we continue to feel good about ourselves. But I suppose I'm saying this like I've always, this is not something that I feel like I've always known, really. And I feel incredibly lucky. I think that, my training has helped in some way to get me to a point where I can understand that. I think that there was a long time in my life where I was looking for an understanding, I suppose, of some of the experiences that I was having. And I suppose even to say I was looking for an understanding is probably quite, I suppose in some way an overstatement. I think I was trying to find ways of managing my distress. And I suppose went through a bit of a process of sort of trying to find a substitute parent. And I think having some quite unhelpful ways in going about that initially, substances and food and relationships and kind of noticing that these things alleviate distress in the short term, but they don't really kind of help in the long term. And I think my kind of interest in psychology, but also in becoming a therapist, I suppose, was based on a kind of need to work out what was going on for myself. And I found that really liberating and helpful, to not feel like I was just at the mercy of, you know, this like, I don't know, this mad stream that was sometimes going on in my mind, you know, it's like a whirlpool of stuff that just seemed to be going round and round and round in circles. And noticing that I was getting myself into the same patterns time and again, but really feeling powerless to do anything about it. And yeah, I mean, I remember the first time when I actually reached out to services to get help, and what that experience was like. And I think it does make me feel very ambivalent about being part of the NHS, because my experience of that really wasn't great. So I was obviously, as a standard, offered medication first and foremost, which did nothing but turn me into an absolute zombie. I was just sleeping 16 hours a day. I mean, it was terrible. I couldn't function at all. And the idea that talking about what you were going through would be helpful was just such that wasn't even a thing. It was like, oh, well, take this pill, and then if that doesn't help, like, we can see what else, sort of thing, you know. And I was like, I really feel like there are things that I need to understand, and taking a pill isn't going to help me with that, you know. And so eventually, you know, that was at the time, you'll probably remember this, where in primary care they still had access to counsellors, you know, there were still actual therapists sat in GP practices. So eventually I managed to get through to one of those. And bless him, I mean, tired, overworked, I think on some level felt very disinterested in what I brought. That's how I perceived it now. I feel like, gosh, I think the poor man was just so overrun with what I was bringing that, you know, this idea of offering, oh, we've got these 12 to 16 sessions together, just must have felt like, well, what am I going to do with that? You know, I had to fill in these outcome measures at the beginning of every session, which, you know, I still hate them to this day. I don't like doing them. I think they're terrible. I always find myself apologizing 150 times when I give them out to my own patients. And, you know, I suppose what I was left with from that was that, okay, so knowing that I have a space where I can go to talk, that's helpful. The fact that there was a limit on it made me feel there was a pressure to get better. Like, I couldn't, you know, I had to tell this guy that by the end of the 16 sessions, things had somehow changed for me. And that was a definite, you know, I couldn't feel like I did when I started working with him. Things like knowing the model that he was working from, explaining confidentiality, consent, none of that was really a part of our conversations at all. So I left, and I sort of thought, okay, my therapist has told me that he doesn't like my father. That's cool. Neither do I. You know? But in terms of feeling less distressed about my experiences, that really, I can't say that really happened. And so it felt a bit like a plaster. You know, there was a time when things were better, but very quickly I just went back into kind of doing things as I had done before. I feel like that's only really changed, actually, in quite a big way when I started training. You know, I was very lucky to be on a training course that's incredibly reflective and has a really nice, in my view, a really nice way of seeing human distress that actually allowed me in some ways to take a bit of a step back and sort of not feel so ashamed and guilty of all the things that I was doing that I knew weren't particularly helpful, but felt like I couldn't really do any differently. It's also the first time when I really kind of consciously came into contact with psychoanalytic practices. And you know, during my undergrad, and masters, that was the kind of practice of therapy that was sort of like frowned upon and laughed at, because it's not really science. It's not worth learning about. That's not really anything. And I was lucky that I had 2 years actually in placements where I got to practice a psychodynamic model, and it was literally like I sort of found a way of making sense of the world that was just that fitted and gave me a language or a way to talk about my experiences that felt like I didn't need to be ashamed of myself, like I was a human being with reactions that made sense in the context of my experiences. And so I really, I really took to that way of thinking. I've been in my own analysis for 4 years, and I've recently started to have conversations with my therapist about ending, which brings its own anxieties with it. And I was a bit like, oh, but I can always come back, can't I? And my analyst will go, yes, of course you can always come back. Which again, that makes me, it's very different that to what we're able to offer in the NHS. I've found a parent who is willing to parent me somewhat, to allow me to parent myself. And I think that's I suppose the next step, to see whether, to see in how far I've internalized the parent and able to give myself something good. I think that's been a big struggle. And I suppose, the activist in me kind of feels like somebody needs to go into that NHS system and shake things up a bit. I think we need to, there is the challenge about, this idea that people don't have distress or mental health problems when they're staff. That's one part of it, I think. But I think the other part is also about almost like learning how to be human with each other again, because I feel like, to me, that's something that's really gotten lost, Yeah. I'm not sure how successful I am with this, I have to say. And even in doing this interview, I mean, there's something that we've spoken about before. There was a worry for me, not what would happen if my patients would see this, but actually what would happen if my colleagues came across this. And that, I think that tells you all that you really need to know, doesn't it?
Yeah. Yeah, it does. It really does. I really hear you when you were talking about your experiences of analysis and going through that for a really long time, and helping, wondering what shifts you've made, knowing some shifts you've made, and thinking about the future and what you might have internalized going forward. It's been, mine's also been a long journey through it. And incredible, absolutely, I would say, for sure, life-changing, actually. Very important and in fact necessary. So I hear you on some of that.
I think this is the bit that's like, that's the bit that I want to take forward. It's giving people, the people that I come across, I mean, I call them patients, which is a very kind of, it's a psychoanalytic term. Again, like, it's a term that I've struggled with for so long, what to say, but I suppose nonetheless, I think it's about the space that I was given in my own analysis that seems to me like, God, if I find that helpful, then I assume other people might too. And even if they don't, then I know that with my own analyst, I can tell her when I don't find something helpful. Which again, if I compare this back to my first experience of therapy, as it were, it was very much about making this therapist feel like he was doing a good job. You know, it wasn't about whether I was feeling better or whether I was getting better. It was about making sure that them scores went up every week, you know. And I just think, I mean, from my own experience, it's just not like that, you know. I mean, there were times when I started therapy where, God, it felt like I was being dismantled and sort of had to find a way of putting myself back together, where I was having experiences in my head where I was like, oh God, if I don't hold on to something now, like I'll stop existing. You know, it was like trying to hold on to sand as your sanity, and it just escaping you. But and that's scary. Like, I know how scary that is. I know how frightening it can be to, I suppose, feel like you're. I think that's how it felt to me, losing your sense of self, losing your sense of who you are, and you know, knowing that, I think, is a massive benefit to my therapy work. I think that it'd be interesting to hear what the people think who I'm working with, but I suppose they're coming back every week, so that's something. I think if we get scared, if my analyst, and I suppose that's the truth about that therapist, bless him. I mean, you know, this is not a sort of personal attack on him, but there has to be, I think, a trust between the two people that whatever you're bringing can be heard and tolerated. You know, it's not about making things nice or like bringing up scores. It's about climbing down that deep, dark hole, you know, getting your torch out and encouraging somebody to have a look around and see what's there, because it's scary, but it's not quite as scary if you've got somebody there with you who's willing to, I suppose, be alongside you. You know, that's what we say in therapy, isn't it? Sometimes it sounds like kind of jargony, fluffy lingo that we throw around, but I feel like there is definitely something in that let's like be with your distress. Let's not make it better. Let's not take it away. Let's not undo it. Let's just hear it and let's try and understand where it's coming from.
Yeah.
I hope that is what I bring to my own clinical practice. I think the dilemma the challenge possibly is that I don't think it really works with an NHS kind of mental health service model, because if you put there is something very cruel, I think, in putting a time limit on a relationship in a very kind of concrete and definite way. I can see why, you know, like in a public health service way, but part of me then is also a bit like, oh, but is this like, you know, in our pre-interview chat, we talked about the Foucauldian ideas, the splits, the projecting of the mad parts of ourselves into patients so that we get to feel sane. And, you know, I feel like having that kind of conveyor belt model just enables that more. You know, it's like, oh, you know, it allows that to happen. And so again, I'm kind of wondering, we're packaging things up in a way whereby we're saying this is for the benefit of the service user, of the patient, whatever you want to call them. And to me, there is a massive question about that. I didn't find that helpful, you know. I can't see other people finding it helpful. Yeah.
It does split us up, and it goes into that kind of us them narrative where the staff are kind of if we're talking about those projected processes, you know, splitting or projecting distress into, oh, it's them, it's the people who come to us for help, and they're kind of alleviated of it in some way, and there's a sense of kind of idealization there, and there's, you know, the perfect person who never breaks down, never experiences distress, and then really it's obviously the other side of idealization is denigration, isn't it? That kind of the people always broken down, always and weak, and then we get lots of stigma thriving in that kind of environment, that kind of split environment, which just makes people feel very bad. And then, of course, as soon as you're a provider experiencing distress, you're transgressing. Yeah. Something, you're suddenly walking into a very different space where there's not much narrative, not much structure, not much place to go with that. And I know we're talking COVID times at the moment, and there is some opening about the fact that it's okay to feel distress or stressed because of how everything's had to change very rapidly. And when you look at that in the context of what we're talking about, which has gone on forever, this setup, this deep setup of the us them, then it's almost a scratch on the surface, and I wonder where the processes and the policies around kind of staff well-being and staff stress are going to go after this, or from now on, whether they'll actually really be taken quite seriously and deep dive into this rather larger context, historical setup, and really be reflective of these us thems, or whether we'll just, and we see it as well, things kind of just bounce back to pattern.
I want to be hopeful and say that I feel like we're learning something about it, but I mean, even in the context of COVID, I mean, Lucy Johnston is one of the people who tweets about this furiously, this idea that any distress that arises in the context of a pandemic is not a mental health issue. I mean, there are so many issues around the language that we use. And, I mean, I think services are battling with that as well, is that, well, if there's a pandemic going on and you're feeling anxious and worried, that makes sense. Yeah. Does that mean that you need a mental health service? I don't think it does. I don't, and this is where you're running into problems, is that, like, how can there be a service setup that is humane and kind of acknowledging of distress, but the sense that you need help, or are in need of a professional therapeutic intervention, I think just carries a kind of a sort of stigma, as it were, with it, that almost makes me feel like, well, no, I'm not going to access mental health services if I was going to experience anxiety in the context of COVID. I still doubt, just looking at the kind of psychoanalytic literature, back from the kind of, I mean, you name it, like back Freud, but also more the kind of 50s, 60s stuff. The Menzies List paper about social defenses against anxiety, like that was written in the 50s and 60s, that's still going on now. Like, we've known this stuff, we've held that knowledge for half a century. And, I mean, there is still a reluctance to really engage with that, I think. What I do think is that, activism, integrate mental health, those kinds of things, it will take people actually standing up from within the system and without, from the outside, to say something about that. I don't think this kind of, and I felt this massively during training as well. There was an element of sort of like, okay, I've got to jump through X, Y, and Z hoops to be admitted to this club. And then when I'm in this club, then I can cause havoc, But this process of even, and I wrote about this in my thesis, this like process of doing research. Oh, your feelings and experiences and thoughts and opinions are valued if you can back that up with some research. And I'm like, well, yeah, but also I just feel it. So there is that.
Yeah. And I feel that really strongly, because there's a lot of, obviously a lot of research coming out on lived experience, as you know, kind of at thesis level, which will be published over the next couple of years and things like that. And that's really, really important. It's really important, but it's one ally. just one, and it's one type of thing alongside the lived experience speaking up, you know, the individual narratives, the idiosyncrasy, the, you know, not needing to know models, actually, also just being able to speak and have that valued and validated. So research needs to be put in its place in the same way. It is one thing, and many different lights.
But I think there's also a way of doing research, which, like, there is a certain kind of, it's almost like a hierarchy of what kind of knowledge we value and appreciate. And at the very top of that is the kind of detached, pretend objectivity of a scientist, where for as long as you say that you have absolutely no emotional reactions to what you're doing whatsoever, that's the real deal, you know, that's it. You know, I mean, I don't believe, even in research, that people do that in a detached way. I mean, why are you interested in this stuff? Like, there will be a reason for that, won't there? You know, people who research cancer cannot honestly tell me that they are detached from this subject. I mean, I don't believe it. But we don't talk about that stuff. You know, there's a pretense of being detached that's somehow valued in the culture that we live in. And I think that's really dangerous. I think that's really, really dangerous. You know, a huge part of my own thesis was writing about my own thoughts, impressions, biases about what I was doing, you know, because I bring that, and I there should be, I think, in publications, a space for that to be also read and heard and reflected on by other people. You know, it's I think we for some reason value the ability to detach from distress, both in research and in practice. And I think it's really dangerous and unhelpful. It means that the distress needs to be held by someone else, you know, who's not you. For my literature review, I developed a tool. This was me being like really mega out there. I developed a tool to analyze language used in first-person accounts written by mental health professionals. So I analyzed published, peer-reviewed first-person accounts by mental health professionals where they talked about their lived experience. And I suppose I looked at the how did they talk about that? What were the themes about that? And that, you know, that felt like a genuinely kind of meaningful way of looking at research, you know.
Yeah, I did OPA, and I do believe I agree with you that research has its place, but yeah, within that there is which types of research are more valued than others, and with seemingly, and what's bought into really by you know, the NHS England improvement, you know, the top dogs, as it were, in terms of what's valuable to inform how we put our provision forward. And, you know, you've got the RCTs usually at the top, and then the kind of qualitative stuff is further down. But the qualitative stuff, when you're talking about grounded or IPA, is often the stuff that stays closest to the idiosyncratic phenomenology, you know, the experience of what's going on for people, and a way of presenting that. So yeah, I agree.
Yeah. I think it's just, again, like there are, I think, you know, especially from my perspective, what I'm about to say next is very much coloured by, you know, how I feel, I suppose I've been treated, you know. But I think all of that stuff is in some way in place, not necessarily consciously, possibly unconsciously, to protect people working in those systems from pain. And I don't think that it's right or wrong, as it were. But I do think that people who go into mental health work have a responsibility, I believe that, to reflect on themselves. And, you know, I'm not entirely sure whether I feel like I see enough of that. Like, I think it's really bizarre that people who go into professional mental health roles don't have to be in therapy as like just a given. You know, I think that's really weird. You know, like, it's fine if, you know, there are people out there who don't want to think about themselves. That's absolutely fine. I just don't think the place for you then is to be in the mental health system.
We're working with minds, and we're necessarily working in relationships. And to know yourself is to know the other. And, you know, what I love with people coming in is those people who are coming in aware of all of, you know, all the parts of themselves, even where that's been really difficult. And you know, there's always often a lifelong journey, isn't it? It's not that, you know, you're perfectly processed or anything like that, but you have to have the curiosity and the openness to be able to look at that stuff. But also we have to be able to do that in a system that is open to that as well. Because otherwise there's all sorts of other things that start shutting that down, that it's not okay. You know, it's okay to say certain things, but not other things. Or for those who work with diagnoses, you know, it's okay to have this diagnosis, but not to say about that diagnosis. You know, whatever it is, it's got to be those two things coming together.
Yeah. And I think, you know, in some ways, as you were talking, I was just thinking, you know, it's been 12 years since I've worked in that CAMHS inpatient unit, you know, but in terms of how I feel about how I'm able to use my own experience, my lived experience in my work, in some ways I've not been able to make much progress in kind of feeling like, yes, there is a system around me that will support me. You know, if I do draw on my lived experience, I still feel like if I were to talk about certain aspects of my own experiences, you know, and I mean, like, I'm not saying that you don't need to be careful about certain things. Of course you do. You know, you've got to be thoughtful, and there needs to be a process of reflection, you know, in terms of why you're saying something. That was something that came out quite clearly from my own research, was that, you know, people know when you're saying something to benefit them. And if they feel that, they don't mind if you get it slightly wrong. Actually, people are incredibly forgiving about that stuff, you know. It's more when you are saying something because you're still yourself in the midst of stuff that it becomes really, really complicated, I think. It's not that, you know, from the interviews that I did, it's not that people necessarily judge that or think it's a negative thing, but it shifts the focus of what happens between the two of you. And so I think when you are sharing things, then there needs to be a thoughtful process around that. You know, one of the things that I've started sharing, so I've started since qualifying, I'm getting really brave since qualifying. I feel like now I've got that registration number, nothing can happen to me anymore. I don't think that's true, but I started to talk about the fact that I'm in my own therapy. That's one thing that I've shared quite a lot with the people that I work with. And, you know, I'm hoping that destigmatizes that idea of needing a space to talk and think. That's the context that I talk about it, you know. Well, even I need a space to talk and think. All of us need a space to talk and think. There are other things that I would think that are useful to share. You know, experiences that are incredibly stigmatized still. But I suppose the best way of phrasing it is for me to say, I don't feel like it's the right time. Like I feel like I could get myself into trouble with that. And that's sad, I think. That makes me feel very sad.
Yeah. Are you going to publish your thesis?
Yes.
Excellent. Excellent.
Yes,
We do want it out there.
Well, it was the Viva was really interesting. I got some really lovely feedback from both of my examiners. But it was funny going through the comments, and they didn't necessarily criticise me for it, but they did sort of say, your opinions shine through very clearly. And I was a bit like, well, as long as there's a reference at the end of the sentence, I'm sure that that's okay. But I suppose there's a fear of like putting strong views out there. It's again, actually, going into the profession was something that I felt quite uncomfortable about, was this idea that somehow psychologists must sit on the fence, and I'm terrible at sitting on the fence. I'm not good at it. I don't like sitting on the fence.
Yeah, I'm not good at it either.
Yeah, but having a view or an opinion is not like, that's not what we do. And I was a bit like, I don't know. But yeah, I don't know. I'm excited to see where this will go. I think it's I'm actually really glad I did it, and I think it's a really cool idea. And I do hope that it gets out there, as it were.
It's definitely going out there. For all the people who are watching it right now, thank you very much. I just wanted to kind of draw us to a close and to say thank you so much for kind of speaking over so much. I think goodness me, covered so much. I'm not even going to dare to summarise it, but yes, it's been brilliant to hear your voice on this subject, and I look forward to us keeping in touch, of course, and for the future. And I just think it's been great to hear you. Thank you.
Thank you.